Hypertension is a major cause of stroke, heart failure, kidney disease, vision loss, and cognitive decline. It doesn't just kill people, it disables millions, keeping them from earning a living, providing for their families, doing things they enjoy, and very importantly, being productive employees at their places of work. 45% of adults in the US, that's about 108 million people, have hypertension, and only 1 in 4 has it under control. But it doesn't have to be that way. Those numbers make a big impact on American competitiveness in a global economy and on individual business performance. But we know how to prevent and control hypertension. We know how team-based care and other evidence-based interventions help people control their blood pressure, maintain their health, and in a business setting or a work setting, how they can help an entire workforce become healthier, more productive, and help employers attain higher retention as well as work attendance. Hi, I am John Clymer, Executive Director, National Forum for Heart Disease and Stroke Prevention, and I'm very excited that you've joined us today for this session on the business case for hypertension control. It's a project that has been worked on with great advice from people in the business sector, the nonprofit sector, and the public sector who are employers, as well as people with expertise in not only hypertension and health, but very importantly in business performance. The National Forum has been excited to work with FTI Consulting, who's brought tremendous expertise to not only building the business case, but developing some tools that you're going to learn about today and that you'll be able to apply in your own setting to gauge how much hypertension in your workforce is affecting the performance of your organization or your business. Before we go further, I want to acknowledge the individuals who have been advisors on this project as part of a work group that has been supporting not only the National Forum and FTI, but the CDC Foundation, who's providing the financial support and overall guidance for this project. So beginning with Ohio State University leaders, Dr. Bern Melnick, the Chief Wellness Officer at OSU, and Megan Amaya, Director of Health Promotion and Wellness. From Paychex, Bridget Hallman, Employee Wellness Manager, Nico Pronk, the Chief Science Officer at Health Partners, Jesse Tonaletto, the Wellness Chair from Pierce Transit, Amber Van Allen, Wellness Administrator for the City of Green Bay, Wisconsin, John Summers and Ellen Burkhart, the CEO and VP of Administration, respectively, for Harmac Medical Products in Buffalo. The Chief Health Officer from Wells Fargo, Dr. Brent Paulecki. David Hines, Executive Director of Benefits for the Metro Nashville Public Schools. And Mark Yancey, Chief Executive Officer, and his colleague Peyton Robinette, the Chief Operating Officer for Nashville Health. Now I'm excited to introduce a co-conspirator in this project, partner from whom I learn a lot every single time I'm with her, Meg Guerin-Calvert, the founding president of the Center for Healthcare Economics and Policy at FTI Consulting. And we've been excited to work with not only the CDC Foundation as an organization, but with individuals from the CDC Foundation who brought insight and expertise to the project, including Diane Kolak, Program Officer for Non-Infectious Diseases, and Michelle Bildner, the Project Manager from the CDC Foundation. And now, Michelle, I'd like to welcome you to make some comments.
Thank you, John. And I'd like to thank the National Forum team for hosting this session, and again, our partners at FTI for this collaboration on this project and on this webinar. And John, I'm really glad you talked about all the collaboration that's happened so far, because this is what we believe will help us do our work and get the work done. We are thrilled to have all of you in attendance today. Thank you so much for making the time to be here. A little bit about the CDC Foundation before we get started. Yes, it is based in Atlanta. It is a different organization than the CDC, but what we were founded to do is to serve as the go-to nonprofit authorized by Congress to really mobilize philanthropic partners and private sector resources to support CDC's critical health protection mission. We believe at the CDC Foundation that people, groups, and organizations have greater positive impact and can accomplish more together. For this work, I can share that over the past 5 years or so, we have been working diligently to really advance employer investments in chronic disease prevention and management so that you can improve employee health and well-being. We started this early on with you said it earlier, John, I think it was a team-based care approach, a medication therapy management team-based care pilot approach to preventing and managing hypertension. And we've evolved into a broader systems change work in this space, really trying to make that business case for strategic investment in hypertension prevention and management. And we have a few other projects along the way and on the road. And I do want to pass it over to Diane to share a little bit about an important initiative that you all might also want to join. So Diane.
Thanks very much, Michelle. It's a pleasure to be with all of you today. My name is Diane Kolak from the CDC Foundation. One of those strategic investments that Michelle mentioned is a program called the National Hypertension Control Roundtable. The Roundtable is a coalition of public, private, and nonprofit organizations dedicated to eliminating disparities in hypertension control. And we do that through dialogue, partnership, evidence, and innovation. And we would really love it if everyone on the webinar today would visit us at our website and think about if joining the roundtable is something that you are interested in. It's a multi-sector partnership. We do not charge for being a member of the roundtable. We share really great best practices, and we get together at least once a year and talk about how different sectors can work together and really move the needle on hypertension. So I will put some information in the chat for you, but I hope you'll consider checking us out. That's the National Hypertension Control Roundtable. And with that, I'm going to toss it back over to John. Thank you.
Well, thank you very much, Michelle and Diane. Diane, I'm glad you mentioned the Hypertension Control Roundtable. It is a good group. I learn a lot as a participant in it, and I would encourage people to join and do so now because the annual summit for the National Hypertension Control Roundtable, to which Diane just alluded, will be coming up in September. So now is a great time to get on board, get within the tent and be part of that exchange of ideas and learnings that will bring people together from different sectors. And really appreciate, Michelle, the background on the CDC Foundation. I think a lot of Americans were introduced to the CDC Foundation in a moment of crisis when New Orleans and other parts of that region were underwater following Hurricane Katrina. And some people know it was in the news, but some Americans may not know or remember that the CDC Foundation quietly played a pivotal role in helping that entire region recover, helping the public health community get in and serve the people who were victims and who were struggling to recover from the damage wrought by Hurricane Katrina. So that was exciting, but the CDC Foundation does so much more. This project is just one example, and it's really been a privilege for FTI and the National Forum to collaborate with the CDC Foundation, with Michelle, Diane, and their colleagues on the business case for hypertension control. And now I'm excited to turn the microphone over to the leader of this project, who is Denise Clayton, the managing director for the Center for Healthcare Economics and Policy at FTI Consulting. Dr. Clayton, the microphone is yours.
Thank you so much, John, and thanks to all of our participants who have joined us today to better understand the importance of hypertension control for businesses. In addition to John, Meg, and the CDC Foundation team, I'm also joined by my colleague Jason Than, who you'll be hearing more from later on in the session today. I do want to start by sharing our key objectives for today, so we'll go to the next slide. And first up, we want to understand healthcare costs and productivity loss due to hypertension. Number two, to show you how to use the new budget impact model we've created to estimate the impact of hypertension. And number three, to show you how to use the claims analysis guide to gain an even more detailed understanding of how hypertension affects your workforce. Next slide. So with those objectives in mind, here's our agenda for today. After the introductions and overview, which we've mostly gotten through, we'll talk about some relevant background information on the impact of hypertension on the workforce. After that, we'll transition to the two specific tools that we've created to help employers estimate the impact of hypertension on their own organizations. The first being the budget impact model. Then we'll have a break before we talk about the second tool, which is the claims analysis guide. And after that, we'll have a small panel discussion with two employers who have relevant programs to discuss, so we can hear firsthand about what employers are doing and why they decided to act. And finally, we'll wrap up and conclude by 3 p.m. Eastern Time. Before we jump into the background, I do have one housekeeping item. I wanted to point out that we'll have two designated points in the webinar today where we will pause and answer questions from you all in the audience. If you would like to ask a question, please use the Q&A button at the bottom of your Zoom screen, not the chat, to either ask or upvote a question. Feel free to post your questions to that Q&A. Again, the Q&A, not the chat, as soon as you have them. And we'll do our best to answer what we can, both as we're going through each section and at the designated Q&A portions of the meeting. So with that, we're ready to get started. First up is a poll question. So I'll give our tech team a moment to get that pulled up. The question is, does your organization currently have a health or well-being initiative or specific health benefit design, such as reduced costs or cost sharing of medications, to encourage the prevention and control of hypertension for your employees? You can select yes, no, or not sure. So I'll give you just a few moments to put in your responses to that first of 3 poll questions that we'll have for today.
Well, responses are already flying in, but let's give it about another 10 seconds. All right, last call for any poll responses. And here are your results.
Great. Well, thank you for everyone who responded. Let's take a little look at the results. We have 48% who do have an initiative, 15% that do not, and 37% who are not sure. I think that's really interesting. I'm glad we have such a range of experiences for the employers and stakeholders who have joined us today. The great thing about today's session is that no matter where your organization is in terms of supporting employees with hypertension, we hope to expand your understanding of both the issue and the interventions that you can pursue to help your workforce improve hypertension control. So next slide, please. All right, so as we discussed, we'll first be starting with some general information and background on hypertension before showcasing the 2 new tools that we've created. Next slide. So how common is high blood pressure or hypertension? Well, Hypertension is the most common health condition among employed adults in the US between ages 18 and 59. And it affects more workers than either diabetes or depression. So you can see here on the slide that roughly 3 in 10 employed adults have hypertension, while 2 in 10 have depression and 1 in 10 have diabetes. And there can be a lot of variation in how many people have hypertension across different industries, which is one of the reasons we've created employer-specific tools to help understand impact. So as an example, 29% of sales and office workers have hypertension, while that figure is nearly 40% for installation and transportation workers. Next slide. So why should businesses care about hypertension in the workforce? Well, there are certainly significant financial reasons, which we'll get to in a moment, but employee well-being is an issue that affects factors critical to a business's success. And in a survey conducted by FTI Consulting of investors and employed professionals, 1 in 3 respondents indicated that strengthening employee health and well-being should be a top priority for CEOs. So understanding how hypertension impacts your workforce is the first step in being able to take action to improve hypertension control and therefore employee well-being. And that's what we're here to help you with today with the 2 tools we'll be discussing. Next slide. So in addition to broader employee well-being, hypertension specifically is an area where employers can make a big impact because there's still a lot of unmet need. So what do I mean by that? If you look at this slide, you can see that the top bar shows that 30% of employees with hypertension are not even aware of their diagnosis. Beyond that, if you look at the bottom bar of employees diagnosed with hypertension, at least 35% do not have it under control, meaning they still have high blood pressure. So if you think about these 2 points combined, that means there's a lot of room for improving the health and productivity of employees with hypertension. And lowering high blood pressure does make a big impact. It's been shown to decrease the risk of stroke, heart attack, heart failure. Next slide. So let's talk a little bit more about the health impact of hypertension before we go to the costs. First, I want to point out that employees with hypertension are more likely to have other chronic diseases compared to people without hypertension. So roughly half of employees with hypertension have at least one other coexisting health condition, and roughly 40% of employees with hypertension, people with hypertension, have 3 or more coexisting health conditions, such as high cholesterol, diabetes, or coronary heart disease. And evidence shows that around 20% of individuals with hypertension have evidence of coronary heart disease or stroke, so there are serious implications of high blood pressure. Next slide. So since we've talked a lot about the business case for hypertension control, here are some figures that might get your attention and the attention of your CFO and other leaders, given that many large employers are self-funded, meaning they pay the direct medical costs of their employees. In the left-hand box, you can see that healthcare costs for individuals with hypertension are 44% higher than individuals without hypertension. So an employee with hypertension has annual costs around $3,600 higher than an employee without hypertension. And when you look at costs in specific settings like the emergency room, you see really big differences in the cost per visit as well. So in the ER, cost per visit across all causes is a little over $500, but the cost for a hypertension related visit is more than 5 times higher at almost $3,000 per visit. And as the right-hand side box shows, these costs are projected to grow. Through 2027, medical costs due to hypertension in the employed population specifically are projected to increase by $25 billion, which is about 15% from where they are today. Next slide, thank you. All right, as an employer though, the costs of hypertension in the workforce are not limited just to those direct medical costs, because absenteeism and impacts to productivity also affect business performance and financials. So there are 2 key points we've highlighted here. First, tying back to the earlier slide that shows the rates of uncontrolled hypertension, we see that employees with uncontrolled hypertension have 2.3 times more hours away from work compared to individuals with controlled hypertension. And the other point I want to mention is that the annual cost of time away from work for hypertension is 4.7 times higher than that of diabetes. So putting together the prior slide with this one, not only do employees with hypertension cost more in terms of medical costs, they also cost more in terms of absenteeism and a productivity impact. And further, having uncontrolled hypertension has an additional incremental impact on absenteeism. Next slide. The great news that I have to share with you today is that there are things employers specifically can do to improve hypertension control in their workforce. So the two types of programs I want to talk about are innovative insurance design programs and specialized benefit programs. You may have heard the term value-based insurance design, or VBID, which is really just a term to describe lowering or removing financial barriers to high-value healthcare services. In terms of hypertension, this could mean eliminating copays for drugs that treat hypertension. So as an example of this type of program and some of the benefits, I want to share a case study. A large employer in New Jersey actually implemented an innovative insurance design program where they reduce copays of asthma, diabetes, and certainly in certain cardiovascular drugs, mostly hypertension. So they reduced copays from 20% coinsurance to either 10% coinsurance for retail pharmacies or 7.5% coinsurance for mail order pharmacies. And the great thing is that this program was formally evaluated and written up in Health Affairs, so we have really solid evidence about the impact. The researchers found a statistically significant increase in medication adherence, meaning more people were taking their hypertension medications as prescribed and not missing as many doses. And what happened when their employees were more adherent to their cardiovascular medications? There was a 26% decrease in hypertension-related office visits and an 85% decrease in hypertension-related emergency room visits. They also found that per enrollee total spending, so that's including prescription drugs plus medical services for the cardiovascular and hypertension group, showed a significant gradual decline over time. They estimated that the per enrollee costs for the cardiovascular group were $2,100 in the second year of the program and $3,700 lower in the third year of the program. That's a per enrollee per cost savings. And while the employer saved money on direct medical costs, a reduction in emergency room trips also means employees missed less work. The second type of program I want to talk about is a specialized benefit program whereby an employer can offer employees direct access to special health-related services related to hypertension. These services could be heavily subsidized or completely paid for by the employer. And the goal is to increase disease awareness, increase access to healthcare and services that improve control, and encourage healthy behaviors. So as an example of this type of program, there was a program where employees in a city in the Midwest, as well as employees of a supermarket chain, received one-on-one meetings with a specially trained pharmacist. Before the program, only 52% of hypertension patients had their blood pressure under control. After the program, that went up to 70%. And then not surprisingly, the cost savings followed for hypertension patients. They found that emergency room visits and hospitalizations went down, resulting in lower overall costs of roughly $300 to $400 per patient per year. So with that, we've concluded the hypertension overview. I hope you've learned 3 things. Number 1, hypertension is very common and is impacting employee well-being. Number 2, hypertension drives significant costs, both in terms of medical spending and costs of reduced productivity. And number 3, there are things you as an employer can do to improve hypertension control and thus workforce health. So for the next portion of the session, we're going to share tools that we created to help you understand how hypertension is impacting your employee population specifically. I know I just shared some general information about the cost of hypertension, but you might have found yourself thinking, well, my business is different, or I wonder how much hypertension is costing us. So to help you answer that question and understand how much hypertension is impacting your organization, we're going to go over the budget impact model next, which I'll turn it over to my colleague Jason to cover.
Yes, Thank you, Denise. Hello, everybody, and thank you for joining us today. My name is Jason Than, and I'm a director at the Center for Healthcare Economics and Policy at FTI Consulting. So before we move on to learning more about the budget impact model tool, I'd like to start with the poll for the audience. So you'll see the poll pop up. So this is a two-part poll. The first question is, have you heard of budget impact models? Yes, no, or not sure. And if you have heard of budget impact models before, have you used one? Have you used any tool like this to estimate budget impact on your organization? Answer choices are yes, no, or not sure. All right, so I'll just give it a few more moments for the audience to vote on these two poll questions, and then we can look at the results.
Yeah. Good results so far. Let's give it a few more moments. Last call for responses.
All right, so we see a range of experience in the audience. So about 40% of the audience has heard of budget impact models, 46% have not, and then 14% are not sure about budget impact models. So of those who have heard of them before, the majority have not used one before. So this is great. If you have not heard of a budget impact model before or used one, do not worry. This is exactly why we're here today. We are going to be going through it in detail and trying to understand how to use a tool like this. All right, so we'll start out with an overview of the budget impact model, and there will be a demonstration of how to use the actual tool. So to help employers build a business case for hypertension, we've created this budget impact model as a tool to use. And as Denise was saying, you might be wondering, how much does hypertension cost for my specific business, because we have learned about differences in healthcare costs in the general employee population. But to estimate it for your own organization, this is a tool you can use to do just that. And this tool is designed for self-funded employers, but other employers can also use it to get an idea of the healthcare costs, that the trend in healthcare costs, how much hypertension be costing that could impact the premiums. And also they can estimate productivity loss costs for their employees. So users can enter employee population specific data into the model, but most data are not required. The only thing that is required is the total number of employees in your organizations, which is, I think we could all get the number or estimate that number. All other data that is described here, such as demographic characteristics, wages, and healthcare costs are not required, but the more organization-specific data that you enter, the more precise estimates you will get from the model for your specific organization. There are default values built into the model based on published studies, and you can use those if you're not sure or you don't have the data. If you do want to get more specific data to enter into the model, you can work with your internal teams to get specific data points or use claims reports from health benefit providers if those are available to you. Next slide. So after we enter the data into the model calculates additional costs or extra financial impact of hypertension on the organization. The results include estimated number of employees who are covered under your health plan with hypertension, additional annual costs of hypertension, so that includes healthcare costs and productivity loss costs, and the model will also estimate total employer costs. You can save these results, you can export them and share them with your internal teams and senior leadership to show impact and take next steps. So you can run the model in two ways that we'll show on the next slide. The first way is to run it for your entire organization. So I want to estimate the impact of hypertension on my entire company. Or the second way you can do this is do the entire population, but also I want to learn more about hypertension by different job functions within my company or different departments. So you can do that, and you'll be able to select the industry that your company is under or various job functions to estimate industry specific hypertension estimates. Next slide. So you can also enter demographic information if you have the data, but as I mentioned before, you only need to enter the total number of employees to use the model. Demographic information such as age, sex, race, and ethnicity can be entered on a screen like this. And another input that you can enter here is the percent of employees that are covered under your company's health plan. So that will help us estimate the cost and the proportion of employees with hypertension. On the next slide, the model will also use the proportion of employees with hypertension if you have this data for your specific organization. But if not, you can use your specific industry's average, which are available on this tab here, and you will be able to see this when we do the demonstration. On the next tab, you will see that you can enter average healthcare cost data, wage data, and productivity data to estimate the impact of hypertension on healthcare costs and productivity loss costs. You don't have to enter these data if you don't have them, because you can use the default values and which are based on the US employee average. And after we enter all of these data, we will see the results on the next screen. So the model will show a dashboard at the top with the key information that would be useful for you to estimate the impact of hypertension. So you can see here that on the dashboard, there will be estimated number of employees with hypertension, additional annual cost per employee due to hypertension. So that's the cost of hypertension, the cost for employees with hypertension compared to those without hypertension, and what the difference in those costs are, and the total additional cost for the employer. You will see that there are detailed results shown in graphs and table formats that you can open and export these data to be shared with your internal teams. There are a couple of great points in the chat that I will address, but if you have any questions, please enter into the Q&A function and we can answer it live here. And if we don't get to your question, we will follow up and also share additional insights with you via email as well. So there was a comment from Karen and David stating that the number of 20 covered employees with hypertension seems quite low for a population of employees with a median age of 43. This is a really great point. We did enter 500 employees into the model, so that's a small employer. However, hypertension prevalence, or the proportion of employees with hypertension, differs based on the industry. So what we've had put into the model was the professional specialty as where our hypothetical company was under, and I believe the hypertension prevalence in that industry is around 14% or something like that, as opposed to 33% in some of the industries. So that has an impact on the total number of employees with hypertension. One of the things that the model, one of the things that the model can do is actually take into account various subgroups as well. So if you have different job functions, you can really select different types of job functions for each department, and then different prevalence estimates or proportion of employees with hypertension will be applied to each subgroup. And as we also showed in the demonstration, we put in 40% as the proportion of employees that are actually covered under the firm's health plan. So that also takes the final estimate also takes that into account. So that is also why the number 20 might seem small for an employer of 500. Are there any other questions? I'm looking through the chat. David had a question for the business representatives on how they feel about an $80,000 number generated from the tool. Would that amount make the organization act? That's an excellent question. We would love to hear insights from those on the call, as well as when we do get to the employer panel session later in the webinar. These are some of the questions that we will answer with these two employers who have, taken some data into account when taking action and making decisions. That's a great point. Any other questions? Okay, well, if anything comes up as you listen to the webinar about the budget impact model, anything, please just drop into the Q&A and we will follow up. We will now have a short 5-minute break, but after the break, we will learn how to use the claims analysis guide and also hear from the employers discussing their experiences with managing hypertension in their employee population. Thank you.
All righty, thank you, everybody. Hope you had a good break and have had a moment to get back to your desk here. We're looking forward to sharing next about the claims analysis guide. And after that, we'll be having a panel discussion with two employers who have hypertension programs in place, who I hope can comment on that $80,000 question from David Shapiro. Next up is a poll question, actually. And so we wanted to ask, do you have access to employee healthcare claims data? I'll pause to let you all read the answer choices first before reading them. So again, the question is, do you have access to employee healthcare claims data? Choice A is no, we do not have any access to employee healthcare claims data. B is yes, through third-party provided reports with predetermined types of information. C is yes, through a third party that can provide reports and custom analyses to support decision-making. D is yes, we have access such that we can analyze the data directly as needed. And E is applicable, not applicable, or don't know. We'll give you all just another minute to input your answers there. All right, so you can see there is a little bit of variety here. We have people who have said no. We have people who have said yes through third party. Some directly have access to data that they can analyze themselves, and a lot of you don't know, or it's not applicable. So, that wide variety in terms of employer experience with claims data is really to be expected. And the reason we wanted to ask about this first is because the claims analysis guide can be used for employers across the spectrum of experience. And the goal is really to show you the ways in which you can use data to better understand hypertension in your workforce. So the first thing we're going to cover here are the key questions that you can answer by analyzing claims data. And then second, we're going to show you how you can use the key questions in the claims analysis guide, kind of no matter where you are on this spectrum of employer experience. Next slide. So here we have the 3 key questions that we cover in the claims analysis guide, which employers can use to inform interventions or insurance benefit decision-making. The first question is really fundamental. How many employees have hypertension? As we saw in the budget impact model, we can estimate how many employees in your organization have hypertension using data from prior studies, but with claims data, you can directly assess how many employees have hypertension. And for example, how many employees are newly diagnosed each year to understand not only the size of the problem, but also to what extent it is changing over time. The second question we have is, what are the costs related to hypertension? As with the prior question, this is a figure that can be estimated with the budget impact model, but you can also use claims data to dig into total direct medical costs. And you can also look at costs by various categories, whether it be by age, race or ethnicity, the care settings such as hospitalizations or doctor's visits, or even the cost by treatment category, meaning, costs for patients who receive a pharmaceutical intervention versus costs for those who don't. And you can also, to Ellen's point on the budget impact model, you can look at the costs by neighborhood characteristics. We know healthcare and outcomes are very much tied to community. So you can directly measure how costs vary across, say, zip codes and their associated community characteristics with a measure like the Social Deprivation Index, or SDI, which is all outlined in the guide. The third and final question covered in the claims analysis guide is how many employees are treated with medication for hypertension. This helps you understand how many employees you have that may be untreated and who could possibly benefit from programs that aim to improve access to therapies. As a sub-question here, you can also measure adherence to medication by using standard measures such as the proportion days covered, or PDC. This term, adherence, and the proportion of days covered specifically tells you the percent of days in a given period that the patient had access to the medication based on their prescription refills. So you might find, for example, that the adherence as measured by proportion days covered, or PDC, was only 50% in your employee population, telling you that employees are only taking their medication 50% of the time. It could be really useful to know if a figure like that improves with the initiation of a new program that, say, reduces copays for those medications. So these are the three questions that we go into detail about in the claims analysis guide, which also shows you the specific sub-questions you can analyze to better understand hypertension in your workforce. And there are more than even the ones listed here. You might, like me, see these questions and think, yeah, I'd love to know the answers to those questions, but you're not sure how you would go about using the claims analysis guide, given your organization's experience working with claims data. So with that in mind, we've now got our next slide up, which covers how organizations with different levels of experience can use this claims analysis guide. So to help you understand how to use the guide, and this full flow diagram is also in the beginning of the guide itself, we first ask, do you have access to employee healthcare claims data? So go ahead and advance the animation. If the answer is no, then the budget impact model is really the best resource in terms of estimating the direct and indirect costs of hypertension for you. So recall that direct costs are medical expenditures, indirect costs are the costs associated with absenteeism and reduced productivity. However, that being said, I'll add that you can still use the claims analysis guide in future discussions with potential vendors or your payers who either currently have or would in the future have access to your employee claims data. And the purpose is to let them know what kinds of things you want to be able to do with your data. So if you're looking for a new benefits vendor to help you understand medical spending and your benefit design, use this guide to see which of these key questions they would be able to answer. Can they provide, custom analyses such as these? The guide itself spells out exactly how to answer these questions and how to identify employees with hypertension and their costs using the claims data. So you can use the guide to say, would you be able to do any of this for me if we move forward? So that's one opportunity for people and employers in that left-hand category. So now back to the top. What if it, answer to the question is yes. So it could be that you have an external partner that stores and analyzes the data, or maybe you analyze the data directly. If you're in the partner vendor scenario, you can use the claims analysis guide as a framework for discussion about the specific outcomes you'd like to understand from your data. You can provide the guide to the partner or vendor and specify which key questions or outcomes you'd like for them to calculate. hey, we would like to know how many of our employees have hypertension and what they cost annually compared to people without hypertension. The claims analysis guide document actually, lists the questions that you can ask and provides instructions on how to use claims to answer those questions. Now, on the other hand, if you're in the process or the situation where you or your organization are analyzing claims data directly, then you can use the process and methodology section of the claims analysis guide, which provides a detailed description of how to answer each of those key questions with that data. It tells you how to identify employees, how to calculate all of the outcomes that we discussed in the key questions. And then I also like to add, as described in the gray box at the bottom right of the screen, you can complete these analyses before implementing any type of hypertension or well-being program to help you understand the baseline scope of the problem and also some of the nuances of the problem. And in addition to that, you can perform them annually or on some periodic basis going forward to understand if you're making any progress. This could be especially useful if you implement a new initiative to support hypertension control, and then you want to assess, how much is this helping? In what ways is this helping? Is it improving adherence? Is it improving cost? So the claims analysis guide contains this flow chart. It has the key questions from the prior slide and details on how to answer each of the key questions using claims data, either for you to use directly or for you to give to a partner or vendor. We will be sharing a beta version of this claims analysis guide after the webinar, and we're very interested in any and all feedback on this tool to make sure it is as useful as possible for you all and for employers. So with that, I think we're ready to transition to our final kind of segment of the webinar today, which is a panel discussion with employers. So with that, I'll turn it over to John Clymer.
Well, thanks, Denise. As somebody who's studied the effects of uncontrolled hypertension on people's health and their well-being, it's really exciting to see today the impact of hypertension on business and employers, and to make the claims analysis guide and business impact model available to employers. Now we're going to hear from a private sector employer and one in the public sector about their experiences helping employees improve blood pressure control. Joining me is Jake Flates, the Director of Benefits and Wellbeing at Paychex Incorporated. Paychex, you may know, is the leading provider of payroll, human resource, and benefits outsourcing services for small to medium-sized businesses. Paychex itself has over 15,000 employees, and Jake is responsible for the strategic direction and management of all corporate benefits. Got to call out his title, Director of Benefits and Well-Being. I think it is just so smart of Paychex to include well-being not only in Jake's title, but in their business strategy. During his tenure, Paychex has been nationally recognized for its innovative approach in integrating the company's employee benefits and well-being programs. And joining Jake and me is David Hines, the Executive Director of Employee Benefits for Metro Nashville Public Schools. Metro Nashville has over 11,000 faculty and staff who serve an ethnically and racially diverse student population of over 80,000, making it one of the largest public school systems in the country. David brings diverse experience to his work at MNPS and to our panel today. He worked in claims management at Blue Cross Blue Shield of Tennessee before he became Director of Operations for the State of Tennessee Employee Health Plans. In the private sector, he was benefit manager for Nissan Motor Manufacturing and a benefits consultant. And additionally, he was insurance director for Rutherford County. There's a lot more, as you see on screen, about both Jake and David's bio sketches, and they're also, in addition to being on screen, on the website. So I commend them to your attention. Now, our goal for this conversation is for you to learn at least one thing from Jake or David that you can use to help your own company or organization and its employees benefit from improved hypertension management. And to cover as many of your questions as possible, Jake and David are going to keep their answers to 60 seconds when possible. I'd like to open with the same question for both of you, and I'll begin with Jake. What prompted Paychex to pay attention to employee hypertension and then to invest resources in managing it?
Yeah, thanks, Sean. It's great to be here too. It's real interesting because if you looked at just our demographics, we were pretty young when we started paying attention to hypertension in terms of an average age of less than 40, right? And we know that hypertension tends to be more prevalent, as we age. But we really thought hypertension provided us with not only an opportunity to improve blood pressure control, but also a great access into the entire topic of managing chronic conditions. It lends itself to monitoring in a safe, quick, easy manner. Certainly there are aspects, and I'm sure we'll talk about, around lifestyle changes as well as medication adherence. And so it was a great opportunity for us to begin that overall approach to improved chronic medical condition management, leading to greater, improved health, and from a business perspective, improved productivity, but more importantly, having a positive impact on our employees' lives.
Great. Thank you, Jake. David, same question for you and Metro Nashville Public Schools.
Sure. When I showed up here about 16 years ago, I sat down with my board of trusts and we had the discussion about our basic mission, and I told them where I wanted to go, and they agreed with me. Fortunately, was to look beyond the cost of healthcare itself to that overall health and productivity paradigm, knowing that basically healthy employees are better employees. Blood pressure is one of those things that you can manage, you need to manage, and there's a variety of things that go along with it. And then you look at that whole cardiovascular line and the comorbidities that are out there. I started at MNPS. I put in on-site clinics back in 2009. And one of the areas that we focused on was the chronic disease management. And so when we looked at chronic disease management, felt like the low-hanging fruit was diabetes, cardiovascular, and asthma, COPD. And so we strengthened everything around there, from giving free care to giving free medications as appropriate for those different disease states, to try to impact people's overall health and the overall healthcare cost as a result.
Thanks, David. You didn't use the words value-based benefits or value-based insurance design, but I think you were talking about it right there. And that I think shows an approach to employee benefits that is distinctive in that many employers view employee health as a cost to be minimized, and employers like yourself view it as an investment to be maximized. And I'm wondering what information you need to feed into your C-suite, into the financial decision makers, to have their support and then to maintain their support for that approach. David, you want to go first, and then Jake?
Sure. Value-based design is very much at the core of everything we do. I mean, it truly is. I used to believe in skin in the game. I don't believe in it anymore. What I've noticed is that, if you can remove financial and physical barriers to care, people actually will receive more care and do better as a result of that. So when I talk to my board of trusts, who I report to, I'm fortunate. I have a combination of union management where I have teachers union reps along with board members, along with our CFO and a retiree rep that I work with, to make the pitch about what we're doing overall will help us control costs in the long run, and also improve the teachers' outcomes and have the teachers in the classroom. With us, it's a different productivity measure. I know that, there's a significant drop in education if a teacher's out of the classroom for more than 10 days. And we need our teachers healthy and well. And if anything caused increased blood pressure, COVID did the last few years. And so it's having them well and healthy and taken care of is critical to success.
Thank you, David. Jake, what information did you need to bring to the C-suite at Paychex, and what do you need to bring on a continuing basis?
Yeah, I think, first is just a sense of the overall health status of our population and how that relates to like our direct medical and prescription drug spend. And then when we go a step beyond, we start to break it down by category. What are folks facing? And today we're talking about hypertension. So we want to understand, the direct spend on hypertension, but then we look also at lost work days, which has a real meaningful impact on the business. Unlike the Nashville Metropolitan School District, I would think it's the case. My wife's a retired school teacher in the Rochester area, that if she was out, they called a substitute in. When we have employees out at Paychex, we don't call a sub in. And so the team members that are in that day have to pick up the work of that individual that's absent. So lost work days have a real tangible impact on the business and the costs associated with it. What we're starting to look at is even a greater line of sight around other business metrics that we're bringing to the C-suite. So we want to understand the health of our population, of our employees, and the potential correlation between things like net promoter scores or client retention or client losses, and how are folks performing in the business. So those are a little bit harder metrics. And the other thing that I think it's real important for businesses to think about too are a little bit softer. Like, when we offer these programs and we do things that help our employees improve their lives, how do they feel about the business? Does it have an impact on retention for employees? Does it have an impact on engagement? A lot of that data is self-reported, but we believe, when you're using validated instruments, that the data is meaningful and accurate. So I think there's that piece of it too, in terms of, the perception that we create, the feeling that we create among employees when we're taking care of them.
Yeah, and Jake, I'm sure Paychex not only wants to be a high performer within its industry, but you also want to be an employer of choice in the community. And at the same time, I think Paychex has taken an interesting approach to helping to raise the whole tide so that all the boats are rising in Rochester. Can you talk for 60 seconds about that?
Sure.
And what's the business benefit to a particular employer being part of a community effort like that?
Yeah, we really started, John, back in 2010. And with a group of employers here in town, prominent employers that got together in a multi-stakeholder effort. So we involved the physician community, the health systems, community-based organizations, and said, let's tackle, and we decided to tackle hypertension. And we did it in part because we knew that blood pressure control was more of a challenge among the underserved community here in Rochester, real socioeconomic implications, as well as race and ethnicity issues, particularly among the African-American population and Latino population compared to the white population. And so we said, hey, let's kind of come together, keep our focus, and see if we can't do something to improve blood pressure control, because we know it leads to a lot of other significant issues. And I'm really pleased to report that, we were able to kind of do this rising tide, lifting all boats, and across, whether we look at it socioeconomically or race and ethnicity, we improved blood pressure control by 10 points in a 10-year period. The thing that we were a little disappointed about was that we weren't able to eliminate the disparities that existed. So it really was that rising tide lifting all boats, but we still at the end of time have disparities that exist. For example, in the African-American community, where blood pressure control is lower than it is among the white population. And so we've got work to do what it meant for the businesses, aside from just being a good corporate citizen and doing good work, I think that's our labor pool. That's our talent. Where the talent of the future is going to come from. So I think we have two things: just doing good work, being a good corporate citizen. We talk a lot about social responsibility these days, and rightly so. And then as well as from a kind of a more a little bit of a selfish perspective, is we want a good labor pool. And then, David could probably speak to this too. We know that, commercial payers, whether they're public like the Nashville School District or private like Paychecks, we pay for, charity care, for uncompensated care that exists in the community. And so those costs are passed on to us. So anything that we can do to improve the health of the community ultimately lowers costs for all of us.
Yeah, those are great points. Thank you, Jake. David,
Sure.
I want to shift gears a bit. What are you doing at Metro Nashville Public Schools to help teachers and other employees manage hypertension?
Sure. We've taken a kind of a throw the net wide approach as we deal with hypertension and other cardiovascular disease. We started at first, we removed all the copays from the cardiovascular meds. We set up our on-site clinics, and about half of our employees will end up in our clinics during the year. And a lot of them will come to us either shared with their PCP, and we help with their chronic condition management and any type of acute or convenient urgent type issues as well. Or we become their primary care provider, and they are patient-centered medical homes. So we spend a lot of time making sure we can close the gaps in care. Our clinics also participated, hit the gold level standard on target BP from the Heart Association, trying to make sure that we're doing our part to make sure that we are taking those measurements, and we're doing a good job in those measurements as it goes forward. On top of that, we do have different blood pressure machines around the district. We send blood pressure machines home to folks that's underneath management from our clinics. We rolled out a diabetes prevention plan with Omada. It was very successful. Next step on that was opening it up to hypertensives and those with diabetes already. So we rolled that out, gave that away as well, and still continue to get results there. Just gone hammer and tong against the comorbid situations when it comes into obesity, especially. We have such a wide variety that starts from different levels of lifestyle programs to surgical and medical weight loss programs that we have in place. In fact, we've gotten about 30% of those that would be eligible for a lifestyle medical or surgical program engaged at this point. And we're starting to see some shifts in our cardiovascular trend as a result of that. So it's something that you never stop. You just keep moving and driving, because it's a complex thing and things keep shifting. And so we just keep chasing the wind here. But it looks like we're catching some progress anyway.
Good. So David, you just brought up, as you were talking about comorbid conditions and obesity and diabetes in particular, you marched us right into a question that one of our participants today asked. I want to put a pin in that for just a second and see, Jake, is there anything that Paychex is doing differently or additionally that you could summarize in 30 seconds?
Yeah, well, we just launched one of our first efforts around what's often called the point solution vendor, Hello Heart, around hypertension. And I think one of the things that we did to sort of test the concept here, John, is we focused on our richest medical plan, which has a $300 deductible, $2,200 out of pocket max, very rich. It also, to no one's surprise, attracts a lot of folks that have medical conditions, including hypertension. And so our intent was, hey, let's test it and see if we can actually get really good self-management going on, self-care going on that's reportable. And why not do it where we think we have the most opportunity to impact? Really pleased to say the initial results look really, really good. We're going to be extending it to the rest of our population soon. But I would tell employers, like, you don't have to start out big and throw something across your entire workforce. And again, we're smaller than the Metro Nashville, public health education system, with 15,000 folks. But, with my plan, our richest plan, I was talking, typically right around 3,000 employees or so. So much easier to get our arms around, much easier to evaluate, much easier to promote, and all those good things.
Excellent. Thank you, Jake. David, one specific question related to the comment you made about sending blood pressure monitors home with certain employees. How is that cost covered? Is that something that you pay? Do you direct your plan to cover that? How does that work in 30 seconds?
It's paid out of the health plan. It's actually being managed by our on-site medical clinics. And so it just basically flows through as a supply line on their overall bill.
And do they couple that with education for the employee about how to use the device and what to do depending on what data they receive?
Very much so. Okay. Basically, we use family nurse practitioners as our core providers, adding in a PA right now. But between them and our health coaches and our providers, they take the time to educate them, take the time to follow up with them, because one thing we learned, if your provider asks you to do something, it has a little bit more impact sometimes.
Yes. And also, we know the evidence shows that the chief medical officers in many households, often known as Dr. Mom, have a little bit of influence too. David Shapiro, who's one of our participants today, asked, how does implementing a blood pressure control problem or strategy or program affect strategies or programs to manage diabetes? Is there any tension or conflict there, or are there synergies? If each of you can comment for 30 seconds or so on that, let's start with Jake.
Yeah, I think there's synergies. I mean, we're ultimately, concerned about metabolic health, right? And hypertension is a key, one of the key factors around metabolic syndrome that ultimately, if unchecked, we know one of the outcomes can be type 2 diabetes. So I would say you're kind of hitting things potentially on the front end when you're focused on hypertension, but you can do it. They're absolutely, from my perspective, tied together in terms of improving the overall health of an employee or their dependent.
Okay, great, Jake. David, anything to add to that?
I just have to agree. They go hand in glove, one with the other. No tension. There is some great synergy. As I mentioned earlier, we moved from the OMADA diabetes prevention program into a hypertensive program with the same organization, same format. So much overlay and overlap, but it works together, and it's never a one size fits all. You need to give the programs that meet the people where they're at.
Absolutely. Well, David Shapiro asked another, I think, excellent question, and it takes us back to the budget impact model that Ji-Sin walked us through earlier, and the figure that it generated of $80,000. How big does a number need to be to drive an employee health strategy or decision? It is 80,000 significant, David?
Yeah, basically when I look at 80,000 in my scheme of things isn't significant because I have a spend of about 130, 140 million a year. However, that 80,000 wouldn't be 80,000 for me. When I look at things and modifications to my plan, anything that's more than 0.5%, $500,000 or more, gets attention and gets places on the priority. The greater the number, the greater the priority could be when it comes to overall impact. So,
Jake?
Relatively, it's on target.
Okay, all right, Jake. What about from the shareholder-owned for-profit vantage point?
Yeah, I think what we'd look for, John, is just a positive return. We don't really get too hung up on ROI calculations, because there are a lot of assumptions that underlie that. And so when we look, and we know there are a lot of factors that influence direct medical spend that are really outside of our control. So we're looking at a number of different factors and saying, what does it look like from a direct spend basis? I mentioned lost work days. Are we having an impact there? Is it correlated with improvements in health risk scores? Do we see folks feeling, if they're enrolled in one of our programs, our hypertension program, do they have higher levels of engagement? We believe that higher levels of engagement among our workforce drive business results. So that's kind of how we look at it, without getting overly discreet. But I would say, when we see positive numbers, that's typically good enough.
Okay, great. Well, we're at time for this panel, but I'm going to take the moderator's prerogative here and ask you, this is an impossible way to pose it, but if you can, in 20 seconds or so, share with us what has been Paychex and MNPS's most valuable learning from your hypertension control strategy. Jake?
Yeah, I would say, not unsurprising that focusing on our employees' health is well received by our employees, first and foremost, right? It definitely helps create a feeling of wanting to be here and work here and do your best work. And that's a byproduct to the company. We think, a reduction over time in medical spend is also a byproduct. But it just takes a little bit of courage to go out there and say, like, hey, let's do this. Let's kind of do good work and really focus on, we say it simply here at Paychex. We want our employees' lives to be better because they chose to work at Paychex. And that's what drives our strategy, including the work around trying to get improved hypertension control, high blood pressure control.
Yeah, that sounds like not only an admirable, but a really savvy goal, Jake. David?
Lately we've been doing a lot of work looking at SDOH, races, where you live and everything. One thing that's really bugged me when it comes into hypertension, along with the other comorbidities that go along with this, is what's going on with my Black population. I mean, they are suffering more, and they're more likely to live in the higher need areas, and there's greater impact from a higher need to a lower need, especially my Black population on this. And so when it comes to, if you really care, if there's really an issue out there, and there is, and a lot of it is muddled up when you look at the population as a whole, but if you look at it specifically in the subsets, you see how impactful some of these disease states are, and hypertension is. And it's one of these things that will progress with time and for more serious impact. So let's help out each other and get serious about it, because it's hurting some of the folks that need to be hurt, that don't need to be hurt anymore.
David, that was perfect. Instead of giving an answer, you gave a call to action. And I really appreciate that. And particularly your focusing on disparities, Jake. I appreciated your bringing up disparities earlier, and the imperative, really, not just societal, but the business imperative to close those gaps. And while we're pursuing the eradication of cardiometabolic disease, let's eradicate those racial, ethnic, and geographic disparities as well. Well, Jake Flates, David Hines, this has been a real treat for me, and I hope it's been informative to our participants. I'm sorry that we've exhausted our time, but now I'm pleased to hand the microphone to a colleague from whom anytime I get to meet with her, I feel like I walk away with a couple of additional IQ points. So Meg Guerin Calvert, looking forward to learning from you now.
Well, thank you, John. And just to let you know, there's a concept in economics called Pareto's superior. It's an outcome where it's larger than the sum of the parts. So I, in those conversations, gain IQ points as well. So thank you. So I have the job to really try to wrap this up for us, and I'm really excited about all of the conversations, and particularly thank everyone who has been putting Q&A and chat and so on, because it has really, as you can tell, changed the conversation a lot. And we hope that we'll continue this interaction and improvement. But let me try to just summarize very quickly where we've come today, and then share with you what our planned next steps are. I want to start with David Hines' word about impactful, because where we started with Denise was really around what's the impact, and there were some polling numbers and so on. And what I took away from that was basically that while we all understood that there's a high rate of hypertension prevalence, what we heard as we listened across and in the chat is a sense that the precise number varies depending on the population that you're looking at. And it really matters just to really try to understand that for individual employers and for others. We also heard it's not isolated. If there's hypertension, there tends to be other health conditions and other health impacts. So while we're focusing perhaps on hypertension, we're not doing it to the exclusion of other things. And then what I thought was most interesting, because it's not always there in the literature, was that broader economic and personal and other well-being aspect that you heard, particularly coming from Jake and from David, about the impact of hypertension and whether it's controlled or not in terms of all forms of productivity as well as medical costs. And then, just to transition from there, a couple of takeaways that I was really struck by are the 2 points that Denise shared. One is which, even though there are these known sense of prevalence and impact, a significant proportion of employees are unaware that they have hypertension. And of those that do, a significant percentage are not controlled. That is a fundamental issue. Where there was hope in the transition was the idea that there's now much more alignment between CEOs, companies, senior leadership at all levels wanting to improve workforce retention, productivity, health, and to engage with employers, and employees are seeking the same thing from their leadership, so that we're at an opportune time. I want to jump to the end before going back to the tools. What I took away from listening to David and Jake in particular, what matters, what motivates changed. There were lots of questions that were there. And what I came away from was they're indicating there's no one factor that motivates the change or gets senior leadership, but it is something that goes to removing barriers, but particularly improving outcomes, getting people to be at work and productive at work. But also, Jake really talked about the interrelationships. I want to understand the health status, the linkage to spend, the lost work days, other new kinds of business metrics, and then I want to have programs that are aligned around that. And I'll come back to in a moment, I was particularly struck by not being as looking at different interventions. And I think the kinds of programs that they shared with you are all ones that to me seem like they are doable. And what I was struck by was the idea of having a portfolio of interventions that can be used, not necessarily just a single one. But the takeaway I had is, given what they said, what matters, how do the tools that the CDC Foundation was particularly interested in making available to you today and going forward, how do the beta versions of those tools answer Jake and David's questions as to how to motivate? And a couple of things that I would bring to everyone's attention is, first of all, the budget impact model, as we heard and saw, is usable by every size company. You don't have to be a company with 15,000 employees to be able to use it. You can have a hypothetical or an actual company that has 500 or 200 and still use it to customize it to understand what is the impact of hypertension on your workforce, because the budget impact model already has built into it those kinds of interrelationships between the health status, the population, the demographics, and the various characteristics, including your medical spend and your productivity estimates, to try to give you some of those measures that Jake and David were talking about, or at least approximations of them. So that's the value of the budget impact model, and we look forward to you giving us more feedback on how it can be improved. The other thing I would say is what the budget impact model is capable of doing is it moves it from the abstract, or it moves it from listening to Jake and David as to what they've done, to be in the role of Ellen and Megan, sitting there with the actual model. And, you know, as an economist, I live and breathe Excel spreadsheets and models. But, you know, my mother, others, you know, business managers, others do not necessarily live in that world. And so what the budget impact model attempted to do is to make it very manageable, so that with the limited amount of data, it actually runs for you. And then it puts it out in a dashboard that gives you some of those numbers. What is the medical cost incremental spend, the additional spend for someone who has hypertension as compared to doesn't in my workforce? And then the other thing I would say is it customizes it to your workforce. And that, to go to a point that David raised, is not only that it's what kind of industry are you in, teachers versus plant workers. It also lets you do an approximation to be thinking about SDOH factors. It lets you put together one portion of your workforce that's in a particular area, and it will generate those results. And then very quickly, the claims data gets you that additional step to start look at some of those factors that both Jake and David talked about in terms of, well, how can I think about how significant actually is the medical spend and its drivers? So what are our takeaways? We hope you've learned a lot, as we have today, about, you know, the journey from understanding the impact. Where do we go from here? If I could ask John B, if you could put up the slide. Our planned next steps, as was said in the message, the plan is over the course of the next following weeks, the materials from this presentation are going to be shared with you, including beta versions of the budget impact model and the claims analysis guide. Our ask of you, just as you did today, is review these, give us your feedback so that we can continue to improve the model. Because what we heard today and what we appreciate the interaction is the idea that one can actually, as an employer, customize for your population and get a sense of really what are the drivers in my population, what is the overall prevalence, but then to really get a handle on how significant is the qualitative as well as quantitative impact, so I can really turn to senior leadership and say, if we do nothing, here is what the impact will be, but also then to be saying, as you heard from Jake and David, if we do something, how could we measure what the impact is, not just for this condition, for others. With that, let me thank everyone that participated, but I would particularly again like to thank Michelle and Diane and John for starting us off on the journey and continuing in partnership going forward. I'd like to talk, thank specifically our speakers from the business group, all of those that that John mentioned, but also Jake, David, Ellen, and Megan for really engaging with the models and with the activity. My colleagues at the National Forum and the FTI Center for the great work that they've done, all of those that you saw on screen, and many others. And to then thank you as participants for really making a difference here today, because I think what my takeaway was from one of our earliest sessions is a employer basically saying, I had no idea of two things. One is how big of an impact this is on my business. And then also the fact that I can estimate that impact and be ready to motivate and make change. So thank you to you all, and we look forward to our next steps together with you.